Hello, everyone, and good afternoon or good morning, wherever you're joining us. On behalf of my colleagues at New Welles, it is my pleasure to welcome you to this live webinar on breaking the cycle of heart failure readmissions using outpatient ultrafiltration therapy. New Welles is honored to host this educational webinar to provide perspectives from world-renowned heart failure expert clinicians regarding the importance of leveraging ultrafiltration in the outpatient setting to treat fluid overload in heart failure patients. Now, permit me to introduce our esteemed panelists. First, we have Dr. Detlef Venker. He's an advanced heart failure specialist in Central Texas and the medical director of advanced heart failure at Baylor Scott & White in Dallas, Texas. Dr. Venker received his medical degree from the University of Munster and his science doctorate in cell biology and endocrinology from Max Planck Institute, also in Munster, Germany. His research focus is in the areas of cellular biology and heart failure. Dr. Venker is recognized as an authority in advanced heart failure and mechanical support, with prior academic appointments to Yale and the universities of Kentucky, Kansas, and Maryland. Dr. Venker is viewed as a clinical expert in his field and has served as principal investigator for a multitude of clinical trials. He is well published and has presented research at numerous scientific meetings. He serves as a peer reviewer and has published countless articles. Next, we have Dr. Ramesh Amani. Dr. Amani is an interventional heart failure cardiologist and associate professor of clinical medicine, the Division of Cardiology at Ohio State University. His practice focus and research interests are in the areas of advanced heart failure and transplant. He also serves as the director of heart failure clinical trials at Ohio State University. Dr. Amani received his medical degree from Ohio State University and his undergraduate degree with distinction in biomedical engineering from Duke University. Dr. Amani is recognized as an authority in adult and advanced heart failure. He has participated as the site principal investigator for a multitude of clinical trials, presented research, and lectured both nationally and internationally. He has published countless articles and book chapters in the areas related to heart failure. Finally, we have Mr. Pat Corelli. Pat Corelli is the Chief Outpatient Physician's Associate and the lead clinician for the Outpatient Congestive Heart Failure Program at MedStar Good Samaritan Hospital in Baltimore, Maryland. Mr. Corelli received his PA degree from the University of Maryland and his MBA with a healthcare administration focus from Frostburg State University, also in Maryland. He serves as adjunct faculty at the University of Maryland in the PA program. Mr. Corelli is recognized as an expert in treating heart failure patients using ultrafiltration with a 10-year history in the outpatient setting. He was instrumental in developing the provider-led outpatient heart failure program at MedStar, incorporating ultrafiltration. Under his leadership, the program has grown into a multidisciplinary education and supportive model, including nurses, pharmacists, community health advocates, and a patient support group for those suffering with heart failure. Since the project started 5 years ago, MedStar has seen significant improvement in the quality of life of their patients, a 50% reduction in 30-day hospital readmission rates, and an average reduction in heart failure hospital length of stay of 5.2 days. My name is Dr. Linda Hart, and I will be serving as moderator for today's presentation. I come to New Welles with more than 3 decades of acute care cardiology experience, including advanced heart failure as a nurse practitioner. So thank you all so much for joining us today. Next slide, please. All participants will be in listen-only mode. We encourage attendees to ask questions as they have them via the Q&A function. Please do not use the chat function. Participants on this call are advised that the audio of this conference is being broadcast live over the internet and is also being recorded for playback purposes. A recorded version of this webinar will be available 48 hours following this webinar at www.newwelles.com and on the New Welles YouTube channel. Next slide, please. These are our forward-looking statements. Next slide. and our speaker disclosures. Next slide, please. So we have an exciting agenda this afternoon. We're going to review the current landscape and challenges related to treating heart failure patients suffering from fluid overload, discuss a strategy for treating these patients in the outpatient setting, review clinical experience with outpatient use of Aquadex therapy, and then have an opportunity to really discuss how to start a program, the elements that are needed, patient experience, the healthcare economics, reimbursement, and future opportunities, as well as have an opportunity for Q&A. Next slide, please. Current challenges. Next slide, please. So as many of you know, national data suggests that the current standard of care for managing fluid overload in heart failure patients is clinically and economically challenging for patients and hospitals. We are basically faced with a quadruply pronged problem. First, 90% of heart failure patients are hospitalized due to signs and symptoms of fluid overload. Often, even treated, they are discharged with unresolved congestion. This leads to poor clinical outcomes. The second prong has to do with long lengths of stay, averaging about 8.3 days, and high cost of care, with an average cost per patient encounter being well over $24,000. Thirdly, low reimbursement. Oftentimes, reimbursement is only $1 for every $3 spent on patient care, and the picture gets more bleak as time goes on. And fourthly, high admission rates. We know from the data that about 1 in 4 patients are readmitted within 30 days, and about 50% are readmitted within 90 days. So this coupled with high volume, high cost, poor reimbursement, and then also there are penalties associated with these reimbursements. Now I'd like to turn the discussion over to Dr. Imani. Next slide, please.
Thank you. Welcome, everybody. So, I think as Linda sort of pointed out, there's a complex challenge here. And from the clinical aspect, I think we have experienced this cycle of patients coming back in and out for quite some time. And, unfortunately, we don't have a lot new in the last several years that has really addressed that. But you can see here the statistics. I would venture to guess that most of us that see patients, probably see local statistics very similar to these national data. But, ultimately, you've got patients that get discharged that are unfortunately still congested. That's a primary risk factor for coming back. Many of these patients then represent either urgently or unplanned presentation, and then we get readmissions. And so, nearly a quarter of our patients get readmitted within 30 days of a hospital stay for the same problem they were just here with. Those readmissions and only persist over time. So you see nearly half those patients are at risk of being readmitted at the 3-month point. And those hospital stays become long, and they become longer and longer, an 8.3 length average stay from this data set. So this is a problem. This is a problem clinically because it puts our patients at risk. They don't want to be in the hospital. It's a problem financially because we get penalized for this. We don't get paid for 8 days of hospital stay, especially on readmissions. And so this is the challenge that we have had. We're trying to break out of this cycle. And as mentioned, we haven't had a lot of tools that have really effectively broken the cycle, even with some of the new medications and other therapies that have been introduced. Next slide. So you can see, many of us really want a way to appropriately treat these patients without a readmission. We want ways to appropriately make the patients feel better, have a lasting effect on the improvements that we provide, and really change, hopefully, the disease course. But yet, despite this want, this recognized need, we're just not really progressing the needle. We're trying to identify those windows where it's appropriate to intervene on a patient quickly, with that appropriately and fully treat a patient's congestion, which is still the predominant representing symptom. It's worsening volume status. If we can do this in the outpatient setting, right, patients don't have to come back to the hospital, patient satisfaction, quality of life can be improved. It reduces the financial burden on our healthcare system. So all the right reasons to keep looking at this problem and create novel solutions. It's probably not even accurate to call it standard of care. But I think the default that many of our programs have utilized is the outpatient IV diuresis clinics, either in an observation setting and an outpatient setting. And when we're able to do that, we feel like this is a very effective solution to help treat these patients. But those of us that do this also recognize a fair amount of challenges using IV diuresis, both with the shortcomings and the physiologic response to an IV dose of a loop diuretic that may not be as predictable as we hope, concerns about renal function, hemodynamic perturbances, all of those things. And so it's not necessarily as applicable as we'd like it to be, but it does kind of serve as our cornerstone for outpatient therapies. And as a proof of concept, I think those patients that are able to receive outpatient loop diuretics, we see those benefits of improved satisfaction, improved quality of life, and certainly their generalized heart failure care seems to be better. Despite all this, we're just not, again, showing that this is the best way to approach these patients. And I think that opens the door for some novel solutions, some application of technologies that we have available in other settings, moving it to the outpatient setting. That's what we want to talk about here today. I think our next slide. Yeah, so the question here is, of course, can ultrafiltration really offer the alternative solution to that? So I think that cede the mic over at this point.
Yes, hi, welcome everybody. Yeah, so is ultrafiltration an alternative, an additional tool that we can use not only for the inpatient management of volume overloaded heart failure patient, but maybe even for the outpatient? So if you go to the next slide, please. So simplified ultrafiltration, the Aquadex therapy. So ultrafiltration is a mechanical diuretic and natriuretic tool that can remove volume in a very relatively short period of time to achieve patient's improvement, but also result in effective volume removal with the euvolemia. Fluid removed by ultrafiltration is controllable and adjustable. The ultrafiltrate extracted through convection forces removes a significantly higher amount of sodium compared with hypotonic urine produced by diuretics or other pharmacological agents. As you can see here on the right, you have the ultrafiltrate with Aquadex removes about 2 times the sodium compared to diuretics, loop diuretics, 3 times the amount of sodium with adenosine A1 receptor antagonist like rotofillin, and 7 times more sodium is removed with Aquadex than the vasopressin receptor antagonist like tolvaptan. So a huge opportunity, because most heart failure patients suffer from volume or from increased sodium intake and diuretic resistance or diuretic indiscretion. So and sodium indiscretion. So go to the next slide, please. So the benefits of Aquadex in heart failure patients are multifold. There are no clinical change in electrolyte balance. So we're removing isotonic volume solutions that doesn't change the electrolytes in heart failure patients as opposed to diuretics. Aquadex provides a diuretic holiday shown to restore diuretic responsiveness. So after effective volume removal via Aquadex, you achieve euvolemia that allows us to discharge patients with a much lower diuretic dose than initially, meant to maintain its euvolemic state. And Aquafreeze has shown a 53% reduction in the risk of rehospitalizations for heart failure compared to diuretics, significant benefit that has been studied in multiple studies. And early initiation of ultrafiltration in heart failure patient has shown to re-establish euvolemia and might even decrease the hospital length of stay over time. If we can go to the next slide. So I want to, I think this is the outpatient Aquadex program. I think this is Dr. Imani again. I think this is your slide.
Pat Corelli.
Hi, everybody. Thank you for having me. I want to thank New Welles in particular for giving me this opportunity. This slide's a very good slide, and I just want to reiterate, we're talking about alternative solutions here to managing heart failure, and the system's been relatively the same for like 50 years now. But now we have a new way of managing these patients. If you look at this picture, it's similar to a prior image we saw. If you look at the patient home on the left and follow the red arrow underneath, the general path of a heart failure patient is compensation at home, and then they end up in the hospital. That's the picture on the right. Then the picture on the right, the hospitalized patients are, the hospital staff is doing their best to get this patient out under the constraints of the current reimbursement model, teeing the patient up so they're safe to go home and sending them back home. And the process starts all over again at decompensation. We have a couple models that we follow here at MedStar, and I'll talk about the first one, the continuation of care model. And that is when a patient comes into one of our institutions, massively volume overloaded, clearly decompensated, generally unstable. And we recognize that IV diuretics aren't doing the trick. We'll go ahead and transition them to ultrafiltration. And then once the patient becomes stable, then we let the patient basically go home, and they're transitioned to me in the outpatient world, generally the next day. What is stable look like? Well, that's subjective, but the patient has to feel well enough to go home, and they have to demonstrate hemodynamic stability as well as no significant, lab abnormalities that make it unsafe to leave the hospital. But when they come to me in the outpatient world, then I continue ultrafiltration generally 3 times a week, 2 times a week, whatever the patient can do, whatever transportation allows. And we get our blood work right there in clinic. We monitor them with RNs. It's similar to the inpatient care, except now we're doing it on a stable patient who was otherwise unstable. Remember, a lot of these patients are sitting in the hospital so we can collect their urine. In a nutshell, that's what happens in the hospital with heart failure patients who we are just trying to diurese. They've generally had a workup. We know their history. We know their echo findings. We just know they decompensated, and now we got to fix it. So a lot of this can be managed on stable patients as an outpatient. And then we have a separate model, which is the maintenance model. And these are patients that are in the hospital all the time that we know very well, again, have had extensive workups, generally catheterizations, the whole works. And we just know that for whatever reason, they become diuretic intolerant, or their compliance is such that we cannot get them to take their meds. And we know for the maintenance model patients that they've tolerated ultrafiltration in the past. So I will get a central line put in them tomorrow morning, and at 8 o'clock and at 9 o'clock, they come up the elevator to my clinic and we start ultrafiltration on them. This really is a paradigm shift in how to manage patients, because now we're finding we can really have a lot of success doing this as outpatients. This doesn't have to be captive to the inpatient world. And if there's any further questions about this, I'd be happy to explain our process. Thank you.
Great. Thank you all so much. Were there any other comments from the other panelists, Dr. Amani or Dr. Venker, before we move on to the discussion? Good. Okay. Next slide, please. All right.
All right. Yeah. So, thanks, Patrick, for sort of sharing your guys' model and, the clinical experience of a now, I think, very robust and mature program. I may take everybody back a few years. When we first started looking at the use of ultrafiltration in the outpatient setting, we collected a little bit of data and did a little pilot program. And if you can pull up our next slide, just kind of presenting some of that. So we started this off several years ago and collected data on 14 patients, consecutive patients that received outpatient ultrafiltration using the Aqueduct system. And we wanted to be sure we were doing this safely. We wanted to be sure we were getting the intended result. And you can see there's some of the numeric data, a little bit different in the way we designed it. This was more of an ad hoc type situation for patients known to us in the heart failure program that were calling in stating that their weight was going up. Their oral rescue diuretic regimen plan, whether that's doubling their furosemide or torsemide or the addition of a thiazide or thiazide-like diuretic, just wasn't working. Those patients then came into an outpatient observation area received access similar to what Patrick described, and we tried to shoot for about 8 hours of volume removal a day, up to 3 days done within a 1 week period of time. And if you took the average of what we did for those 14 patients, you can see we saw an appropriate weight loss. And importantly, we did not see a worsening in renal function as measured by serum creatinine. We didn't have a lot of any other adverse events related to the placement of access, the use of anticoagulation in that setting. Thankfully, again, small sample size, but low risk and pretty good results, getting the intended hope of 10 pounds worth of weight loss and stable creatinine, all of which was done in the outpatient setting and avoiding readmissions. And that was really almost 80% of them did not end up being admitted in that 30-day window in there. And so from this, we really did conclude that this was a good potential way to treat selected patients to both, again, completely decongest them, particularly in that early warning period of failure of response to oral diuretics, as well as keeping them out of the hospital. So I think that's where we have it. And I think now we move on to the question portion, right, Linda?
I think there may be one more slide.
Oh, one more slide.
One of your also in Ohio.
Yeah.
All the data.
Yes. So this was a neighboring hospital down the highway from us, established heart failure program at Christ. So I'll speak on behalf of Dr. O'Brien and his team. They did a similar single center study. Their patient selection criteria was slightly different than ours, but same general concept. And you can see a high risk patient population. 6 months prior to the therapy, an average of 2 admissions. I mean, that's an extraordinarily high heart failure risk when you think about the patients that end up hospitalized multiple times. And you can see even in those situations, the ability to decrease an unplanned hospitalization was quite impressive in there. And really, they in the more robust data set that they presented at HFSA several years ago showed, again, safety as well as efficacy in removing fluid. I think
Great.
now we're on to our next slide.
Now we're on to the next slide. Yes. So great. Thank you so much. So now we'll enter into some discussion, and I really hope that next slide, please, that this will give the audience a good flavor for sort of a soup to nuts, what all is needed for a successful program. Obviously, there's work beforehand, and how do you run a program, et cetera. So when we think of the patient selection, I mean, that's usually a top of mind question. So I'll start with Dr. Venker. What types of patients do you think would benefit from this outpatient therapy? I mean, I know Pat Corelli talked a little bit about the 2 models, but when you're trying to think, I want to start, I want to be successful, who am I going to have the best shot to sort of get my feet wet with this program?
Yeah, it's a very good question. I think the key is probably to identify patients that are resistant to diuretic therapy. So that are not only volume overloaded and decompensated, but most importantly that don't really respond and lose effective volume with conventional therapies, meaning diuretics. So these are, and from my experience, we started actually an outpatient Aquadex approach to a patient with severely diuretic resistance in 2006. This is before Novellis actually was managing this company. There was an outpatient approach with an outpatient catheter that was placed before the patient came to our infusion center, and we removed volume effectively for a number of days. And the limitation at that time was really the lack of reimbursement. We had problems with the catheter that was not the DELC catheter that we have available today, with some suction events that occurred from time to time. But we were able to actually effectively remove volume in 2006. This was at a very early stage and has actually improved significantly since then. So I think the other patient selection, I think important for the patient selection is patients, once they respond to Aquadex via volume removal, they actually show a better responsiveness to diuretics overall. So you can switch the diuretic treatment on again. So it's a switch on, switch off phenomenon. And we often actually use Aquadex in patients that are somewhat responsive. They're not anuric, but partial responsive to diuretics, but have significant volume would take us probably months, if at all, to achieve euvolemia. So in those situations, you often can use Aquadex to support the diuretic effect, and you can see over time that the diuresis actually improves when the patient goes home, and they come back and suddenly they say, well, I'm actually making enough urine now to be weaned off the Aquadex. So that's a significant benefit, I think, combining both diuretic therapy and Aquadex therapy. We don't have to be exclusive one or the other.
Great, perfect. Thank you so much. And Dr. Amani, expand a little bit more too, as we think about, our patient selection and identification, then, how do you determine how long you're going to run the patients in your clinic, and what setting do you typically sort of start with? I know you alluded in the data that you presented to about 8 hours.
Yeah, and that's a great question. This is a lot dependent on the infrastructure that you're able to set up. Our target is 8 hours per session, sort of per day, and understanding that we don't always get exactly 8, but depending on when patients arrive, get checked in and into an appropriate environment. But the hope is to do 8 hours per day. For us, it's up to 3 days. I think we feel like if you're going to require more than 3 days in a short window, that patient may be even a more sick phenotype and may require more intense therapies or workup in the inpatient setting. But the rates also dependent. We now, at the time, didn't have the benefit of data that came out of Avoid, and Dr. Costanza has published some really nice algorithms that we now utilize. So the Avoid algorithm kind of helps us set a UF rate. Ideally, we'd like to get about 250 an hour as our removal rate, and that's sort of our default, with an adjustment down or up pending clinical factors such as blood pressure, renal function, perhaps more of an RV predominant heart failure, or the presence of stenotic valvular disease may make us reduce the rate a little bit. I think if you do the math, one of the things that you have to be a little bit careful about is, if you're using really low rates, let's say 150 an hour or less, and you do it times 8 hours, you're actually not getting a lot of fluid pull per day, and then you got to make sure you're ending up net negative. 250 an hour times 8 hours, or even if it's 7 hours times 250, you're getting very similar to what we typically target in our inpatient setting, which is close to 1.5 to 2 liters of net negative volume removal in a day. So that's how we go about thinking. Is the patient able to tolerate volume removal? Likely between 200 and 250 an hour, and are we able to get them in and do several good continuous hours of therapy? Geographically, that sometimes limits us. Patients that have to drive several hours either have to stay in the area to come back for another therapy in a day or two, or unfortunately, or have to live close by.
Great, thank you. And how about Pat? What do you find in your clinic? Does that sort of your clinic kind of mirror what Dr. Venker and Dr. Amani have articulated?
Yeah, very, very similar, except we run every patient at 500 cc's per hour for 6 hours. We pull 3 liters, which is 6.6 pounds every session, 3 times a week. Now, the advantage we have is we do get blood work prior to while the patient's being heparinized. We have our labs running, so we know initially what their values are in real time, like right before we turn the machine on. We also have, our RNs for the first hour are taking vital signs every 15 minutes, the second hour and third hour every 30 minutes, and then every hour on the hour. Yes, there have been a couple patients that have been highly preload dependent. We start seeing the vital signs get a little funny, and we have to back it down. But I'll tell you, in the last 5 years, I can only think of 2 times we've had to do that. We literally are taking off, we're taking off 9 liters a week, doing the math, it's, we get a lot off of these patients. So we go strong, and we've had really good success with it.
That's great.
If I can add to this, I think we individualize often the speed at which volume is removed. So we're trying to establish a total volume overload the patient is carrying. So if somebody has 20 pounds volume overload, and as opposed to somebody with 40 pounds volume overload, the rate will change accordingly. Our goal is to achieve euvolemia within 5 days of treatment. So that means 20%. So if somebody has 20 pounds volume overload, you need 4 pounds per day to volume to be removed. And then in 5 days, they have 20 pounds volume. So the rate changes based on that calculation. And it's critical to know that most of the volume is extravascular. So you rely on the plasma refill rate. So it's not the creatinine that we monitor, we're creating the hemoglobin. So the hemoglobin, the hemoconcentration, is the most critical aspect of volume regulation in heart failure. I know we in the hospital, we have hospitalists and residents that change your volume removal based on a creatinine change of 0.1 to 0.2 milligrams per deciliter, which is expected. You know we work the kidney hard, so we're creating a significant force, and so we expect the creatinine to go up. That doesn't mean that the kidney function is in any way hurt. It just means the kidney is working harder. And we know 90 days, 30 days after discharge with Aquadex that creatinine is actually better than patients treated with diuretics. So we should not forget about this. I think it's a very important aspect. The most challenging aspect of aquapheresis or any volume removal is when to stop, and that's why I'm pointing this out. Everybody says, oh, I can run it at 500. Are you, I mean, this is too high for me or too low. It all depends how much volume you have in the first place, and whether you have a parameter that allows you to halt and stop. So if you see hemoconcentration, significant hemoconcentration, if you know even the baseline hemoglobin, it's a very easy tool to actually stop it at the appropriate time.
Yep, those are great points. Thank you all so much. And I know that particularly with the SmartFlow, we have the ability to measure the hematocrit and keep an eye on that to allow for plasma refill. Actually, the device will actually stop and allow plasma refill. We also have the ability to monitor SVO2, which serves as a surrogate for cardiac output. So both those things are important. And I think to your point with the creatinine, I mean, Dr. Rao very eloquently presented that data looking at the CARESS data, and those patients that had the rise in the creatinine actually did have better outcomes. So it just kind of means it's working a little harder, the kidneys, but not detrimentally. And I think the importance of knowing our patients.
If I may just add to this, Testani has actually published this data and showed survival benefits. If you focus on hemoconcentration, not the creatinine, you expect the creatinine to go up. I sometimes tell the residents, it's like a balloon angioplasty. You inflate the balloon, you have ST elevations. The heart is suffering from an inflation of the balloon, but you don't stop there. You continue because the end result is a recovery in your cardiac function and perfusion. The same is, in my opinion, the same is true for the kidneys. You see a rising creatinine, that means the kidneys are just working harder, but you see eventually down the road, 30 days to 90 days, an improvement in kidney function once euvolemia is achieved. I mean, it's a significant aspect of this is nephrosarca. The kidney is drowning in fluid and you just have to remove it. We're not talking about 2 or 3 liters of volume. These are patients severely volume overload.
Exactly. And I know, Pat, when I had the opportunity to tour your clinic and share with the audience how you talk to your patients about this is like a full-time job for them or a part-time job for the next period of time. So maybe you can comment on that a little bit so that they know what patients kind of know what to expect.
Yeah, we try not to sugarcoat it. We tell them even before I have IR put the line in that this is a process. This is going to take time. We have some people that can be done in a week. We have some people that take a little longer. Just like inpatient runs it slow so we can monitor things. You're right, creatinine we expect it to go up, but if it goes from 2 to 4, we have to back off on something. We have to change something a little bit. So those are the situations where we have to control our rate, back it down, and then we have to, we know that the therapy gets extended, then so that's where the part-time job comes in. We can't always just say, this is a great thing, it's going to work, and it'll be done in no time. We put the realistic expectations out there that this can take a few weeks sometimes. I generally leave the line in a couple weeks after we're done as well, just in case they get back on diuretics and it's still not working and we just have to start it back up. It just saves the patient the inconvenience of having a line put in all over again. and we'll restart and start the process all over again. And I think that's a testament to, like the doctors are just saying, it's customizing it to the patient. There's a lot of data out there, and we've our whole advanced heart failure team's read it, but it's still a little different for every patient. So we just have to find that right program for each one.
Great,
Yeah, I
great.
think it's a very good point that you made. Creatinine obviously rise of more than from 2 to 1 to 2 or 3, and that's a trend going up. And there might be other reasons for this, or you're just not tolerating volume removal. But we're talking mostly about creatinine changes of 20 to 30%, meaning a creatinine going up from 1 to 1.3 or 1.1 to 1.2. These are the changes that happen frequently with doing volume removal, and it should not mean that you should halt your diuresis. It's actually something that you should expect. And most studies have shown changes of 0.2 to 0.3, so mild to moderate changes in creatinine as a significant change into withholding or causing harm to the kidneys, which is we know today not true.
Great, thank you. And now one question that always comes up, and I'd like to direct this to Dr. Amani, as you think about the patients that are so difficult oftentimes to treat, are your patients that are have somewhat preload dependent, your restrictive cardiomyopathies, your amyloid patients. So how might this Aquadex therapy in the outpatient setting fit into treating those patients that are often very difficult to treat?
Yeah, and I think that, thanks for the question. I think a little bit of disclaimer, right? Because it's a little bit of a data-free zone. We didn't have a lot of those patients, at least identified in the trials. But those patients, I actually like the concept of controlled volume removal. So for what Patrick and Detlef just talked about, all those reasons, the dirty secret that we all understand is if I give 80 of IV Lasix or 120 of IV Lasix, I have no idea how much urine is going to come out either, right? And that creatinine's potential to change, the hypotension can be there. So all the things we talk about and have been publicized with ultrafiltration, I think still exist for pharmacologic therapy, particularly for these sort of unique populations that have sort of very fine balance on their intracardiac hemodynamics. So why not pick a therapy where you can actually control what's happening and then rapidly adjust to the conditions that you're seeing. So your restrictive or restrictive physiologic patients, sometimes you want to make sure you're getting enough out, but balancing how much or how quickly. All of those RV and in our patient population and in that 14 patients that we talked about, we actually had a couple of LVAD patients who had RV failure. So some unique places where I think that this is actually a great way to come in versus the, hey, take 5 milligrams of metolazone. By the way, go back, get some blood work drawn in a couple of days. Call me with your weights. Call me. We'll make another adjustment. We're bringing them in and we're taking a little bit more control of the situation.
Great, thank you. Well, I'm going to go ahead and ask them to come to the next slide, and we'll talk a little bit about venous access. And in terms of, start with Dr. Venker, what type of access have you used or would consider using in the outpatient setting, and talk maybe a little bit about how that's placed, and if you end up leaving it in or putting in a new one each time they come in. I know Pat gave us the insight with what he did.
Yeah, this is the key aspect of offering therapy. And so we're using mostly the DEL catheter, which the dual extended length catheter that is offered through Novellus. It is placed in our institution by either interventional radiology or by our surgical team partners. This is for the inpatient, but even for the outpatient, we have a dedicated team from IR that can actually place this catheter. The importance is to recognize this catheter is a 7 to 8 French catheter as opposed to a Quinton catheter. That's significantly thicker. It's about, you're talking about 14 French. So if somebody sends somebody for scuff volume removal, they go into the ICU and they need a Quinton of 14 French, you can maybe place a 12 or 13. So as opposed to the DELC that we can use actually with a 7 to 8 French diameter and can be used as an telemetry for sure, and even as an outpatient management can be left in, and I would prefer to leave it in for the time being for the week. So we would offer 5 days a week treatment, so from Monday to Friday. And by as I said, 5 days is our goal to achieve euvolemia, which is easily achieved. the patient comes back and you would continue volume removal subsequent days. You could extend for another week, but you don't have to in most cases because the patient becomes more responsive to diuretic therapy, unless they're really in end-stage renal disease and on dialysis. And we can talk about this as well because we work with nephrologists on that part. But that's basically the catheter that we mostly use, the Delco catheter.
Great, perfect. And how about you, Dr. Amani?
Yeah, we tend to use the Delc catheter a lot as well. So when possible, we do that. And, if you're anticipating multiple sessions, we do leave that catheter in place, much like you would a midline or PICC line dressing change, sterile dressing before they leave our institution. They come back, and on the day that we decide is their final day of therapy, we take it out. The nice thing is it's short term. They don't require home health or a lot of care. You just give a patient caregiver some basic instructions on what to do and what not to do with that dressing. In situations where that just isn't feasible, be it venous anatomy or some other challenges, the two peripheral 18 gauges actually work well. If you can get good 18 gauges in, not right here in the AC where as soon as they bend their arm, which is actually the same truth of the Delc. That serves as an alternate option, and that those peripheral IVs we will take out at the end of the day and then reinsert them when they come back for their next session.
Yep, that's great. Also, and you talk about the 18s, and I know that we've also become aware of some other just right off the shelf IVs that will work too, looking at the gravitational flow rate of the catheter and then compare that to what is needed for success of our therapy. So we're certainly happy to work with people with those sort of options too. I think that having a peripheral option does sort of open up, just another venue for people to have access, no pun intended, to the therapy. They may ultimately need some other kind of access, but I think, maybe in the short term or whatever, that does become an option if they don't want to have a indwelling line. So great. All right, next slide, please. So the other thing that's really important, we know access is super important, and then anticoagulation is important. So Pat, I'm going to start with you in terms of how you approach anticoagulation. And then the question always comes up about oral agents such as warfarin or DOACs and how you sort of navigate that.
Sure. Yeah, for sure. We do, we heparinize. We, pre-heparinize about 30 minutes prior to starting the machine. That's generally when we have our labs cooking on the patient. We just run it at a basic 1,000 units per hour. I get a call from our pharmacy every single time. What are you treating at only 1,000 units an hour? And I say, it's for the filter, just relax. And they're like, oh, this is Pat. Okay, never mind, it's just Pat. So that's what we typically do. And even with warfarin or DOACs, we still heparinize. And this is just, anecdotally, I suspect because we run our rates so high, we need heparin in there to keep it. Once we heparinize, we never have any filter problems. It seems like a patient who's had a history of HIT or we don't have heparin readily available for whatever reason. There was a couple times we had some shortages of that, and we did run into some issues that basically required us to cut back our rate. And I suspect that's why heparin is so important to us. But yeah, that's generally how we do it, just 1,000 units an hour, and we never have any issues.
Okay, great. And Dr. Venker, any comments on anticoagulation? Oh, you're muted.
Sorry for this. Yeah, I can only echo this. I think it's important to use heparin if at all possible. If somebody has HIT, so we have to use argatroban and alternatives, obviously. But you risk losing the filter. That's the main issue with a patient. But in general, it doesn't happen very often when you really can use heparin. So that's the safest way to go by.
Perfect. Thank you. And same with you, Dr. Amani at Ohio State.
Yeah, we similar approach. We use we still call it sort of the standard heparin scale. In 8 hours, how often are you going to get therapeutic? So there's a bolus and get them up at a high rate. But we will check our PTTs at some point during the day just to kind of adjust, mostly to adjust up in case we're a little bit low and bolus in there. But we agree that, you know, the use of heparin is important even when you're on other oral anticoagulants, as you sort of pointed out. And in those situations, we have the patients continue their oral anticoagulation, warfarin uninterrupted. If they're going for a line placement, we'll sort of figure out the DOAC based on indication for DOAC. We would prefer to keep them on it if IR is a little bit uncomfortable, or our vascular access, our PIC team is uncomfortable. You know, we may have to hold that DOAC agent for 1 to 2 days prior to, and that's probably all the more reason to be on heparin. For patients who are on uninterrupted oral anticoagulation, we switch down to a fixed rate non-titratable heparin. So our standard is actually to use 5 units per kilogram per hour as our fixed rate heparin, and we think that that helps protect the filter. We make sure that goes into the withdrawal line. Whether this is voodoo or not, I can't tell you, but the idea is that the highest concentration of heparin is then hitting the filter first before it gets back into systemic circulation.
Great tips. Thank you so much. Next slide, please. Okay. So this is a big question that comes up too, is how do you go about building consensus, and where, if you're starting a program, where in your institution do you run this therapy? So we can start with Pat, and then we'll jump to Dr. Amani and then Dr. Banker. So thinking about spaces and that sort of thing.
Yeah, so this is a good question. You know, our facility is kind of an interesting evolution. Things really fell into place. But what is now our heart failure, you know, outpatient heart failure clinic was an infusion clinic prior to that. So heart failure started piggybacking into the infusion clinic. So we had it already set up with chairs and TVs, kind of like a dialysis clinic, actually. And then when infusion went away and actually joined oncology somewhere else in the hospital, we still had this facility here. So this is several thousand square feet. And we have basically like 11 chairs, 11 stations for patients. And it turned out to be perfect for this because nursing could easily keep an eye on everybody. We have some centrally located seating for patients on ultrafiltration so that they could be, you know, watched closely. Monitors are all facing the nurse's station. So for us, I realize this isn't what everybody, you know, has the blessing of having to start out a program, but for us, it worked out really well. And that's generally how we did it.
Great. Okay. Thank you. And Dr. Baker, I know you're getting ready to start a program there in Central Texas. So what kind of spaces are you looking for?
Yeah, so my experience from the East Coast when I was here was an infusion center that we started then, and I mentioned it before that we used Aqueducts there, and the same would be here. I think we like the combination of IV infusion therapy, IV diuretics with the Aqueducts is probably a good opportunity to start the program. So for the infusion center, you need actually one dedicated APP and one nurse and a nurse's aide for every 4 chairs roughly. So if you have, you know, 8 chairs, we double the staffing for this. And that has worked actually well for us in the past, you know, in other institutions where we started this. The other, I think, important aspect is that we often work with nephrology, even in patients who are oliguric anuric, you know, so they're already on dialysis, and then often they're challenged with volume overload, believe it or not, because many nephrology centers don't even have the time or the staffing to do 8 hours of volume removal with scuff. You know, they dialyze 3 times a week for a good reason, because the spots are very limited. So we have collaborated with nephrologists very closely, because they see us initially as competition to offer volume removal on off dialysis days when the patient is not making enough urine. And that has been really been welcomed by nephrologists. And we see a significant benefit in patients that are waiting for heart kidney transplant, for example, that we can optimize the volume status and get them safely into heart kidney transplant by removing the volume as an outpatient rather than admitting the patient a week before and optimizing the volume status. We know, all of us heart failure specialists, that the volume status is not optimized in most hemodialysis centers, because I don't think you can get away with taking volume off on 3 or 4 days a week. You know, you can't just say we optimizing your volume status by 3 times dialysis, hemodialysis. It's not sufficient. You know, you need to urinate every day, unless you stop drinking one day. It's impossible to do this, in my opinion. So that's why I think the collaboration with nephrology, so offering aqueduct volume removal on off hemodialysis day, is a huge benefit for patients suffering from even end-stage renal disease.
That is great. I'm going to skip to the next slide because we've got about 10 minutes left, and there are a couple other really important topics I want to make sure that we hit. So Dr. Amani, talk a little bit about the patient experiences that you observed in your study and with your experience.
Mm-hmm. Yeah, I think we maybe I'll work backwards here, because the feedback we received has been almost universally positive. I think patients really like having this as an option. Whether it's inpatient or outpatient, I think there is something to actually showing that patient that bag of fluid and saying, look, this is what we just took out of you. And, you know, that really helps them feel like they're getting appropriately treated. You know, then again, to say you're going to come in, get this treatment done, and then go home, it's all that much better. You're going to sleep in your own bed. You know, you're going to spend an evening with your loved ones. So I think they really do appreciate that. You know, expectations wise, and sort of what we tell them the typical day is going to look like. You know, it's a commitment. I think somebody mentioned, you know, to treat it as your job or your part-time job, and that's right. Now, you know, these patients are typically not feeling great, so I don't think there's a lot of convincing to say, look, you also didn't get sick in a 4-hour window, so I can't give you a 4-hour, you know, treatment. You got to commit to coming in. You got to commit to getting hooked up. And these patients have been hospitalized before. Let's be honest; they know what it's like to be in a hospital, and when you really just compare it to that hospitalization, or, you know, not to, you know, completely belittle our ED colleagues, but man, you threaten a patient that they have to go sit in the ED, and man, they want anything and everything else done that's an alternative. So, you know, we tell them, you're going to come in, we're going to get an access point. Hopefully we've, you know, sort of discussed that ahead of time and know, you know, the multiple vital signs, right? If they've not had aquapheresis done before, we got to sort of warn them that you're going to have every 15-minute vitals. You know, some of the limitations with, you're not going to be roaming the hallways while you're hooked up. You're going to be in a nice recliner chair. You're going to be in a nice environment, you know, and hopefully you're going to feel better. And then, you know, you got to temper expectations, you know, for those patients that are the 20 and 40 pounds up that we talked about. Like, it's going to take a couple of days to get you better, but, you know, we really do believe you will be better. And, you know, I will sell that. Your diuretics will work better afterwards. I think we're not only going to make you feel better in this short window, we're going to have a lasting effect. And so we're sort of selling the long game to them, and they do respond well to that discussion.
Great, thank you. All right, well, next slide, I think, is going to talk about the future opportunities. So I think we talked a little bit about that with Dr. Venker, the sort of either in dialysis clinics or using it concomitantly on off days with dialysis, and then also a little bit of at-home therapy. I'm going to jump to the next slide because we've just got about 6 minutes left, and talk a little bit about the healthcare economics and the reimbursement, because that's always on people's mind. So let me start with you, Pat, just to talk a little bit about in terms of the program that you had and how you've been able to reduce readmissions and lengths of stay.
Yeah, like we said before, you know, we have data that does show, you know, length of stay reduced by, I think what we say 5.2 days, I think it was, when compared to a cohort group who had similar disease but did not get ultrafiltration. We also find that Maryland is a little peculiar in its reimbursement model. It's different than all the other states. I know every other state's, it's kind of strange too. You know, you get that ding for the 30-day readmit, but Maryland itself is even more peculiar than the rest. And that goes back like 45 years. So, but our reimbursement is actually quite good for this. You know, we get anywhere from, you know, $1,800 to $2,200, you know, per session. That varies quarterly, you know, at exchange rates reimbursement, that's still our number. But you know, we've had success with the reimbursement, and we, I won't say it's the driver of our clinic, but it does make it, you know, cost effective, and we're not taking a loss when we do it. So that makes it another arrow in our quiver as far as treating these heart failure patients.
Great. Okay. And Dr. Venker, did you want to comment?
Yeah, I can comment on this with past infusion center experiences. And I think it's critical to understand that every hospitalization increases the mortality on patients with heart failure. We know this quite well. We would love to have a randomized controlled trial to prove this, that is specifically that Aquadex that can prevent hospitalization can also improve the survival in these patients. But just based on our observation, it's a huge benefit for these patients staying out of the hospital. And I personally have, an idea would be to offer this therapy even at home to patients before they get decompensated. We didn't discuss very much the opportunities for virtual monitoring, CardioMEMS to identify patients in need and volume removal that are refractory. The class 4 New York Heart Association function class 4 patients did actually worse with CardioMEMS than with conventional therapy. And this is probably because they have so much extravascular edema and volume overload that is not identified by an intravascular monitoring system, the CardioMEM. So these class 4 patients would probably great benefit from something like Aquadex once they identified. So we need to probably address this on time to prevent readmission to the hospital. So it's a challenging population. And the reimbursement is in favor now. I think I remember from 2006 there was no reimbursement, and we were not supported by to continue with the program. I think this is a great opportunity to help patients really recover from heart failure and prevent them really from progressing with heart failure. We know that extreme volume overload will progress the heart failure conditions, myocyte apoptosis and other mechanisms, and that we are all very much aware of.
Great, thank you. So not only the reimbursement piece, but also the mitigation of risk. And Dr. Mani, I know your program before too, that reimbursement became a problem, so it shut down. And now that there is reimbursement, you all are looking at it through another lens.
Correct. Yeah. And I think we had support from the administration, at the time to try to really see what we can do to advance the overall treatment of our heart failure patient. We're still very interested, both from a program standpoint and administration standpoint, to offer the best available therapies. Healthcare economics are a reality, and you can't lose money and shut down the hospital. So now that reimbursement is, more of a consistent and predictable pattern, I think there's a lot of interest in restarting. I'd say we run the same with all new technologies or applications of technology. CardioMEMS we're a big fan of and still utilize heavily, but CardioMEMS reimbursement was a challenge at the beginning too, and we sort of had to be very measured with that. So this is really, hopefully Aquadex is following no different of a pattern, that as people recognize the benefit as an institution, as a healthcare system, you can see that there's a lot of good to it, and it'll grow in a way, and then the more we use it, the more I think we'll mature that reimbursement aspect.
Yeah, great. And you both, I thank you for bringing up the CardioMEMS, because that's such a nice marriage to be able to identify the problem and then Aquadex providing the solution. So that was excellent. Thank you.
And let me just add one more thing to the CardioMEMS. I don't think the CardioMEMS is not useful for class 4, but the therapy that's available to these patients, that's increase another diuretic. They're already on maximal diuretic dose and they're in class 4 heart failure. So that's why I think we could bring them in, offer Aquadex, and then allow them to recover and then continue monitoring CardioMEMS. That was really my main point.
Yeah, excellent. Thank you so much. And I just want to turn it over in the last few moments we have to Pete Olson, who is actually from New Ellis. And if you'll go to the next slide, please, it should talk a little bit about reimbursement for the audience.
Yeah, so thanks, Linda. So as of January 1st of this year, CMS has assigned a category 3 code. It's 0692T that covers Aquadex therapy. So this code applies a facility payment of $405.37 for the administration of Aquadex in the outpatient setting. It also provides, via a crosswalk code or a proxy code, a physician reimbursement per patient for each day a physician is overseeing Aquadex therapy. So this physician reimbursement applies to both the inpatient and outpatient settings. So there are also reimbursement opportunities, obviously, for placing the venous access catheter, which is required for therapy. And to assist Aqueduct's users with reimbursement matters, Nuwellis is offering a free service with its partner MICRA to assist with both medical justification and claim documentation, and to help with claim denials. Again, this is a free service for Aqueduct's users. Nuwellis is obviously working actively to secure a permanent Category 1 code for this therapy, and we expect that to happen sometime in the near to intermediate future. So if you want any additional information on reimbursement, please get in touch with your local representative, or you can contact MICRA directly via the contact information at the bottom of this slide. So thank you, Linda. Back to you.
Great. Thank you so much, Pete. And if you'll hit the next slide, please. And I think we're at the top of our hour. So to our panelists, thank you all so very much. It was a very interactive discussion, and I just appreciate all your expertise. Hopefully we left with some answers and maybe some questions as well. So I would encourage our audience to please reach out to us at Nuwellis, and we will be more than happy to put you in contact with any one of these experts on our panel who I'm sure would be willing to give more guidance. So thank you all so very much. Hope you have a wonderful day.